Yeah, sorry.
Do I need to adjust the camera? Or,
Do I need to just stop the camera?
I have to watch my head as I'm doing so. Good. All right. Good morning, everybody. Thank you, Kelly, for a wonderful introduction. So I'm sure it will be an amazing day. So I am going to talk to you a bit about our registry, PTEN registry, and I'm going to introduce some people as we go along as well. And I'm going to be followed by Ellie, who's going to give a more personal viewpoint of the registry. So the key people involved. So this was really set up between myself, Catherine. Yeah. So Catherine's based in Southampton, and actually, you've got more experience with PTEN than probably anyone else. You've been doing it a long time. So so we set that up together with Rob Semple, who's in Edinburgh as well, and other people involved are Angie Brady.
Wait, you said
Yeah. Angie is a clinical geneticist in Northwest 10 check service as well. So she's been very helpful in helping us get this going, and also Andrew Latchford, who's going to give a presentation, a virtual presentation. He's a gastroenterologist at St Mark's, and so he's very interested in more of the gastro side of things as well. And lastly, but probably most importantly, Katerina. So Katerina is our new study coordinator.
Hello, everybody.
So please do come and say hello to her during the course of the day, and she can tell you everything about the registry. Okay, so she's the most important person to talk to.
It's a pleasure to talk to you all.
Very good. So what's the point of this actually? Well, it's really to, PTEN is a rare condition, and what we're trying to do is, and it's always difficult to study rare conditions because to actually study something properly, you need data. And to get data, the more data you have, the better quality answers you're going to get to the questions that we all have. But actually in medicine, you often need, and Chris will back me up on this, you need a lot of data, actually. It's not just small amounts, it's big amounts to actually get accurate estimates. And that's something that we really struggle with. A lot of the advice that we give you is based on very small numbers of individuals, small studies done, some of them have done quite well, some of them not so well over many years. And that makes it difficult for us to give you very precise and accurate information. And so really the goal is to, and we know people with PTEN are having treatments and seeing doctors up and down the country, but no one's really collecting that data properly and systematically. And the goal is really here to do that and to actually get enough data together so that we can answer some of the questions that we get asked all the time in a more accurate manner. And it won't just involve the UK. It does need, we do need to share these data with other centres in the world, because that's the nature of the condition. It's a rare condition, and that's the only way we're going to get the best answers is to share data. This is anonymously, it's shared anonymously, but it will be shared. Particularly, we have fantastic collaborators in the Netherlands and also in the US as well. So this is really important, and this is where you can do a lot to help actually, because we all want the answers to these questions that you ask. It's frustrating for us when we're giving you answers when we know we're not really that sure ourselves often about what are the correct answers for. So we want to understand. We want to have a better understanding of the condition. This will lead to better patient outcomes, in terms of management and treatments. It will lead to better multidisciplinary approaches as well. And it is actually the potential, to have a multidisciplinary clinic. I mean, Kelly's already mentioned that. But if you have the data together, then that will give us enough information to show what the need is and what the clinical requirement is. And that's when you're negotiating with the NHS to set things up. They want that sort of information. So again, it's really important that we can provide that. I mean, no one knows how many people in the UK actually have a diagnosis of PTEN at the moment. We can't give you a proper number. And that's something that the NHS will want to know, actually, when they're setting up new clinics. So it's even very simple questions like that are difficult to answer at the moment. And also, there's the whole field medicine is advancing rapidly in terms of improving surveillance for conditions like cancer and improving treatment and prevention treatments as well are coming on board. And again, if we want to be at the forefront of that with P10, then we already need to have a good data set and a good registry of individuals who we may be able to contact to set these kinds of studies up. So I mean, I'm sort of trained in adult medicine. I look at P10 more from an adult perspective, and I think I compliment Catherine quite well, who looks at it more from a paediatric perspective. And one of the things that I'm interested in is the cancer risks in P10. And these are some of the figures that we currently use. Now, I'm pretty sure that these figures are overestimates, and that's partly because what we get is bias. When we're trying to collect these data, it's difficult to, you want a whole picture. You don't just want those individuals who have a diagnosis of cancer to come to you, and because that will colour actually the judgment that you have in terms of what the true numbers are. So these, mainly based on small studies, and we think we probably think they're overestimates. Certainly for the female breast cancer, there has been a large study quite recently where the risks are actually much lower than that. Now there's other problems with that study, which might mean that they've underestimated it, and the true figures lie somewhere in between these high figures and much lower figures. But these are all questions that we still need to answer, essentially. And you can see, the range of numbers is quite big as well. So for thyroid cancer, you're dealing, the number of 6% up to 38%. That's a massive range. So where is it? Where's the true figure? And it's going to vary a bit between men and women as well. Likewise, for renal cancer, huge range of estimate. We know there's some increase, but we don't really know what the level of increase is. So these are all things that we need to know more about. So first thing we did actually was where I got involved was a European collaboration, and this was to get particularly with in the Netherlands. We had a patient representative as well, and Bitty, and we came up with some guidelines some pragmatic guidelines that we felt for cancer that would work, across different European countries essentially, and these are the figures that we come up with. And you can see that for some of them, we felt the evidence was quite strong. The evidence is quite strong. So, for example, breast MRI for women from the age of 30, we thought that was a good thing to do. But for other things, we were much less sure, basically. So, coming down to, do we need to actually have a regular skin examination? Well, we don't really have any data on that. It's a bit of a guess, right? A bit of that's what we think we should be doing, but we don't really know. And for some of these other things, we're a bit in between, like scanning for renal cancer, for example. But this is what we came up with. And actually, there are some differences according to countries in terms of what surveillance might be being offered for different cancer types. And so the European one is the one on the far right hand side there, called Genturis, and that is, we also have some UK ones. There were some Dutch ones as well, and we would try to sort of combine them and take the best of both of them, but also be fairly pragmatic and say where there really isn't any evidence, in terms of the cancer risk, or actually whether or not surveillance is effective, then we shouldn't really be doing that on a routine basis. It can be done maybe as part of a research study, but not as on a routine basis. So this actually, went pretty well. We had a lot of discussions over time, and we actually published a paper on it as well, some European guidelines, and also a patient information leaflet there, so that people have got like an at-a-glance idea of what surveillance should be, they should be requesting. The other problem with this is that there's a lot of different organs there, and every organ has its own specialist doctor. So you can end up seeing a lot of different people. And again, I think this is a strong argument for having something much more coordinated, actually, across where so a one-stop shop where you can get all this done in one place, or at least coordinated in one place. and you know, I think that will make things much easier. So coming back to the registry, so what have we managed to do so far in terms of our work? Well, the registry started in 2019, and we've had some green phases where things have gone well. We've had some red bits where, you know, I mean, COVID came into this for sure, and also, you know, I had a coordinator before who you know, did well and then moved on. You know, so it's been a bit stop-start over this time. But you know, we are, you know, ever since Katrina started back in April, there's been a massive boost actually. So thanks to her, you know, we've really got the momentum going again. And coming in today as well, I think is a real boost for our registry as well. So I'm very optimistic. You know, it's been a bit patchy, but I think, you know, things are definitely on the up here. So we've got an idea of what the fields are. One of the things that people get a bit confused about, and I'm just going to really emphasize this, is that we are actually doing two different, for the registry, we're collecting data in two different ways. And one of them is using something called rare renal or radar. And this is basically, it's an NHS based database, or, you know, patient portal, patient information system. But it was developed to focus on people with renal disease. Okay, so there's a whole range of unusual kidney conditions. And that was initially why it was developed. And the infrastructure behind it is fantastic. It is, you know, it's all very, you know, rigorously controlled. It's got excellent data support. It's supported by the NHS. So we thought, rather than reinventing something completely new, we would latch onto that. And, you know, we asked them if they were happy for us to be involved, because there is, and the main link was this, you know, increased risk in renal cancer in PTEN. And they were happy for us to do that. But I think it has created a little bit of confusion. You know, when we ask you to join the registry, you think, well, it's not really, you know, I haven't got renal disease. Why am I joining this registry? And the point is really that that's the place where we're going to, you know, store the data and also update. You can update the data there very nicely as well. So, you know, so the plan in the future is that for those people that have been that take part in this, that then as time goes on, you know, as things develop, we can update their medical, you know, story using this database. And I really like the fact that it is already all, you know, very well established throughout the UK and approved by the NHS. So that is why we chose that rather than starting again, essentially. And actually, they've given us all this infrastructure for free, which is really good as well. So that's, you know, so when you sign up to registry and you see this rare renal thing, it really is a means to an end. It's really our way of using, you know, of collecting data safely and systematically in this portal. We also have a second consent form for a study called ICAP, which is here, which basically allows us to it allows us to collect samples. So, for example, if there's, you know, if you had a biopsy for something, and we wanted to, you know, we'd like to study that tissue for, you know, research purposes. You know, that's the purpose of that. It also allows us to collect medical data as well. So we really ask you to sign up to both of these as part of the registry. The main things we'll ask you about are basic personal information, you know, important genetic information is what we're very, you know, keen to know about as well. So, you know, but you don't have to know these things. All you have to do is give us consent, and we can then contact the relevant genetic services where you've had the testing done, and also any manifestations that you have, and clinical information. And this all gets collected, and we anonymize it all. We pool it, so it's not recognizable. And then we can use it we can share it with other researchers who are interested, you know, who are approved, who want to, you know, because one of the key things is actually pooling the data, as I said, and working with collaborators, particularly in the Netherlands and in the US as well, with Professor Karas in the US. So, you know, so those are really the key messages. We've got a website. And we've also got data sharing possibility to really get a lot of data together, because once we start getting hundreds of data from hundreds of individuals, it becomes a bit clearer. It's really just dealing with 10 or 20. That's not really good enough. But once you start pooling it, and you get hundreds of data points. It really starts being much more useful. And it's been really great to work with the charity as well, PTENUKI, and they made me do a lockdown Zoom video as well. That was quite good fun, actually. You're very good at making me do that. And I think my dog had a little star in role as well. So you want to, if you're into small dachshunds, then there's a special picture. You can click onto that. So there's the website address. There's the relevant email contact, so that will come through to Katerina. I'd like to say a special thank you to everyone who's joined so far. That's been really great. It's not been easy, and we haven't really been in touch with you since. At the moment, we're still in in getting the numbers together. And once we have enough numbers, we will start actually, filling out more and getting more granularity on what we're doing. So we may be in touch again, for updates, for example. And I particularly like to thank PTEN Research as well, who are funding this study. They've been very patient, and also I think they've been good because they don't just provide the funding; they also give us a lot of advice. They've given us a lot of advice over time in terms of how, and help outside of just providing, funding for it. So they've been super. So that's Tom down here. Special thanks to him as well for helping us with this. And so I think that's it for me, really. So if you've got any questions throughout the day, please feel free to come and see me, come and see Katerina in particular. So she's in the oak room, and see Catherine as well, in Andrew here. So thank you very much. And Ellie, you're going to take over? Yes, good.
We're good. If people know me, I'm a waffler, so do forgive me. I'm going to read off my phone to make sure I've got lots to say on this matter. So, okay, I don't have time to waffle, so I'm just going to carry on and just read everything I've got. So, the last few years for me, I've had a very tough journey with the PTEN aspect. And when something challenging happens to me, I like to channel it to good, which is why I'm talking to you all today about exactly why we need to all sign up to the patient registry, which you've just heard about. So being seen at Oxford University, I'm being local, some would say you're being seen by some of the best medical brains in the country. However, my issue is that none of these brains that I've been dealing with have had any experience whatsoever with PTEN patients, which might present what I'm presenting upon screening. Well, personally, I feel very blessed to have the screening in place that's put in place by our genetic consultants. When investigations for me fall out of this standard screening, the mental toll that having no reassurance from clinicians to whatever findings that they're being presented with is something I really worry about for everyone in our community. There are so many times, and I'm sure you all have heard these phrases on this slide, they can make you feel a certain way, and in the end, in my instance, you just got to laugh. So having a PTEN condition, I like to refer it to like a game of snakes and ladders. There's a lot of ups, there's downs, and sometimes a lot of unnecessary steps for all involved. And I just wanted to show you over the past 2 years, here are the steps I've had to go through due to not having a patient registry to refer to see what the results of someone like me should be like. The time, the vital resources of the NHS and the mental toll of these interventions cannot be overlooked, let alone the moaning my husband has to suffer. And he's vouched for that. Actually, this week I was blown away. I emailed some results I received from one of my consultants, my geneticist, and in the same afternoon, she received an email response from our Cleveland clinic to give insight and help my consultant back in Oxford to make decisions for my care. It blew my mind that this shows what could happen when our amazing consultants have the source of information they need to really help us and understand what's happening. So being a PTEN patient, we can spend a lot of time worrying, and trust me, I've been there. But I really want to ask you today to take any worry into action and take part in this registry. Not only will it help our amazing doctors, it will importantly help you, it will help everyone in this room, and even further. With my mum, I said we need to say we shouldn't be in a position where we have to resort to Facebook to check our symptoms with other patients. So please sign up today. That's my waffling on.
Next is on.